Hey, hi you guys. Happy Wednesday. Hi, I've missed you. Welcome back to Warrior Wednesdays. I am so excited. The doctor is back. We have Dr. Cindy M. Duke back on Warrior Wednesday. So get in the room. She's going to answer all of your questions. I already have some in my DM. I'm so excited because it's like, it's like med class in here. Like we learning about our bodies. Hi, everybody. Thank you for joining in. Let me know where you are from. While we get started with Dr. Cindy M. Duke, she is the medical director of the Nevada Fertility Institute. She is my friend. She is someone I look up to. You can find her on Clubhouse. She has a wonderful group called My Dynamic Uterus. And every Saturday, she is talking about women's health, about our menstrual cycle. I listen. I learn all the time. So what's going up? Jersey is in the building. Delaware is in the building. Chicago, Illinois. Hi, how are you? Welcome to Warrior Wednesdays. I know Mama Stu better be in here. Houston, Texas is here. How are you? I'm going to put my glasses on so I can really see you guys and hear you guys. Houston, Texas is in the building. How you doing? Let me see if Mama Stu has joined. Nichelle Polston, you guys, a board member for Resolve. The National Infertility Association is here. Hi, Nichelle. Love you. Phenomenally Autistic is here. Thank you for joining. Mama Stu says she is here. I love it, you guys. I'm so glad you are here. There is so many wonderful things that Dr. Duke is going to be talking to us about today. So what I want you to do, New York is in the building. Hi, New York. What I want you to do is share this live with a woman, a man, a mother, a daughter, a niece, a friend that has something going on in their health that needs to hear this information. Or even if you don't know that, even if they're just, a woman of a certain age that should maybe hear some of this info, I really want you to share this live. Okay, let's get more people in this room. Broken Brown Egg, Regina Townsend is in the building. Ebony Ford is here, also has been a guest on Warrior Wednesday. So follow her at And She Shall Reign. She talked about preemies here. Regina Townsend says she got her Sprite and her notepad. Girl! Listen, we don't play, you guys. We get our questions answered. I can already see that there's questions coming in to the question box. If you have a question, put it in there. I can keep it anonymous if you want, but just make sure you ask. So let me see if the doctor is in the building. Okay, let me check because I already have some DM questions here, so I'm so excited. But do me a favor, like I said, share this live, call a friend, text them, tell them to get on, so that they can get this good information from Dr. Duke. So let me see if she is here yet. Let's see here. Regina says she got her notepad and a good pen. A good pen. Dr. Cindy M. Duke, like I said, is the medical director of the Nevada Fertility Institute. She is Yale trained. She is Johns Hopkins trained. She's an endocrinologist. She is a gynecologist. She's a fertility specialist and a virologist. This woman's medical resume goes long. She goes long, y'all. So we don't play around here on Warrior Wednesdays. So I'm just waiting for her to join and see if she's here. Hold on a second. Let me see. I love all my friends that are here. You guys you do me proud, always showing up in the room. Let's try her one more time. If by chance she's a little bit late or a little busy, she could be delivering a baby or something. She says she's coming. Okay, I just got a text for her. She is coming and she is going to be on here. Woo! Mama Stu says, I love Dr. Duke. Mama Stu, if you have a question, girl, you can go ahead and put it in the comment section because Mama Stu, honey, she be going through it too. We all do as women. It never stops. And we need to know. The Princess Warrior is here from the UK. What's going on? You guys keep sending this live to your friends. Keep sending it to your sisters, to mothers, to aunties, to uncles, to daddies. We all need this information so we can debunk the myths about our health so that we can get all the proper information. People are talking about they love you, Mama Stu, and I love you too. So just give Dr. Duke a second or two. And she's going to be in the building. So excited. There's times where we try to book Dr. Duke, and she's so busy. Like I said, she's out here in these social media streets, but she's also a practicing doctor. She's also,
you know, helping women and men through their fertility journey, implanting babies, delivering babies. Like, she's literally doing all the things. So when she does come, I just get super excited because you guys get such information that, you know, we didn't grow up learning about our reproductive health, did we? We learned about how to make a baby and don't do it before you're ready, but we didn't learn about our reproductive system and how it always works. So it's so good that she's here. Let's see, Brooklyn Batty 204 says, I think I missed what you guys are speaking about. Well, Brooklyn Batty, we are going to have Dr. Cindy M. Duke. She is the medical director of the Nevada Fertility Institute. She is Yale trained, John Hopkins trained, and she is here to answer questions about women's health and fertility. It is a vibe. It is all the vibes in this room, okay? Because we debunk the myths about women and men's fertility here, and we have an expert. We have an expert that is coming to talk to us. So let me see if I can find her. You guys are saying hi to each other, and I love it. Brooklyn Batty 204, thank you for joining. Tell a friend to come by here while we get Dr. Duke coming. Let me try her once more. She did text me that she's coming. So what that means is she might be, Dr. Duke, if you're on here, go ahead and make the request. If not, I just sent you one. But what it means is she might be like finishing up with a patient, and then she's going to hop on. Our miracle child is here, you guys. She has a wonderful book. Please go and follow Our Miracle Child. She's also a fertility advocate. She has survived miscarriage. She has survived the passing of her husband, and she is out here in these fertility streets being a warrior and passing the good news on and educating women. So follow Our Miracle Child. I'm so happy to know her. Follow Broken Brown Egg, Regina Townsend. Follow her blog. It's amazing. She will pray you into next week, honey, and she will make your life so much better. Follow her normal. Nichelle Polston. All right, you guys, thanks for all the waves. I see Dr. Cindy M. Duke is in the room. So Dr. Duke, if you can send a request, or I will send one back to you. Let's say, it says unable to join. Let me see if you can maybe hop out. She says, hi, I'm here. Hi, can you send me a request? Because when I tried to do it, it didn't work. And then we'll get you in the room if you can. And maybe it'll pop up that way. I'll try you again. The devil sometimes be busy, but we do not want to hear it. I'm sending one again. Broken Brown Egg is over there. Hey!
There we are.
Oh, wow. Well, first of all, you look stunning. Hello. Yes. Hair, makeup, everything done. How are you?
I'm good. How are you?
I'm good. It's been like such a long time. And like I said to you, all the warriors and everybody here have been waiting patiently and eagerly for you, because you always come on and share such thoughtful information with so much compassion and empathy. And I just want to personally continuously thank you, because what you guys don't know here in the audience is before I started Warrior Wednesdays, I reached out to Dr. Duke. I simply Googled fertility specialist, Black women, and I started to watch her on YouTube videos. And I instantly fell medically in love with every and all things that you are. And I reached out to you, and you so graciously accepted an offer to just come and talk to me. And that was before Warrior Wednesdays, because you are so passionate about making sure our community is well informed and they get the information. And so I just say thank you. But how are you over there in the Nevada Fertility Institute?
I'm doing good. I'm actually talking to you from my house today. So I rushed home, got quickly dolled up. So if you guys see me fixing my lip, it's because I literally just put on the lipstick. So I'm making sure. But I'm doing good. I got a haircut, or I should say a hair styled into a cut, because my actual hair, full head of hair, is longer. But, you know, I have a partial weave in to make it short.
Me too, child. I got my weave in to make it long.
Yes. And, of course, I rushed to get some makeup on because, you know, my mom, I don't want her sending me messages saying, oh, gosh, you went on live looking without makeup. So I quickly dolled up some makeup. and I
Oh,
hope it's presentable for the
you
audience.
look beautiful. As Mama Sue says, beauty and brains. And hello to your mother. You look absolutely stunning. And
Thank
so with
you.
this beautiful face that you got going, I'm going to go ahead and start with some questions because I already
Yes.
have some DMs. So here we go. You guys get your pens and paper. And like I said, send this to people that need to be watching it live, because if you want your questions answered, you got to be here live for that. So I have a question about a supplement. The supplement is the DHEA
Mm-hmm.
supplement. And the question is whether or not that supplement is effective in helping the egg quality in people with ovaries, and specifically people with ovaries over the age of 40. DHEA.
DHEA is actually a hormone. It's a hormonal
Oh,
supplement.
okay.
It's a metabolite, so a breakdown product of testosterone. And DHEA has been shown in numerous studies to have benefits in a very specific patient group. So it's not for everybody. It's specific for patients with diminished ovarian reserve. So DOR. It's very helpful in that group. So not just for those with diminished ovarian reserve who are over 40, but even if you're in your 20s or your 30s, if you have DOR, and we define DOR in one of two ways. So diminished ovarian reserve is defined as an AMH, anti-Mullerian hormone, less than 1. Or if you've actually gone through IVF and despite all the stimulation medication, you're only able to get 6 or less follicles, 6 or less eggs, not just follicles, but 6 or less eggs, then that's considered diminished ovarian reserve, because no matter what happens, they're not able to get a higher yield from you. And so we have DOR strictly based on AMH, but we have some patients whose AMH is like 2, but every time they're stimulated for an IVF cycle, no matter how high the medication dose is, how much we try to optimize for egg yield, we're only getting 6 or less. That's also DOR.
Okay. All right. Now, and going off of what you just said, because we do talk about AMH, like you said, the
Mm-hmm.
anti-Mullerian hormone here,
Yeah.
and FSH, and
Mm-hmm.
those levels can be checked by anybody with ovaries that would like to
Correct.
check those levels. But can we talk about specifically what the normal range is? And I will just go ahead and be transparent and use mine, because I did just have my AMH checked. I
Mm-hmm.
did just have my follicles checked. You know,
Mm-hmm.
being here on Warrior Wednesdays, everybody that's new may not know that I froze my eggs when I was 37 years old. I got 29 eggs in the freezer. I'm very grateful for that. But, you know, I talk about these things and I can't talk about it unless I'm doing it myself in terms of
Right.
getting my levels checked. So what are the normal rates? For me, a woman in her mid 40s, I just got a level of 3.3. So
Hella high. That's
what
good.
does that mean? What does
That
that
means you're
mean?
probably somewhere in the 90th to 95th percentile for your age, meaning you have more eggs than 90 to 95% of women your age. So that's the way we look at AMH when we're stratifying it, is we look at what we call percentiles. And so we're looking at 50th percentile, which is like the average for your age. And we have standard tables. So for example, whenever I meet a patient and I'm looking at you, I'm not just looking at what your AMH number is, but I'm specifically comparing it to people your own age, because we do have tables and we have ways of looking specifically at your age. So for example, I'll give a few benchmarks. So if someone is 30, on average, we'd expect your average AMH to be about 2.7, 2.8 for a 30-year-old. And so if your AMH comes back above or below that, we can also give you a sense of where you stack up compared to people your own age. If you're 40, on average, we're looking for an AMH around 1.2, 1.3. If your AMH is above or below that, again, we're able to predict and give you a sense of where you stack up. But not only that, because we've been doing this for years, I can actually look at someone based on their age, first factor, age, and then combine that with their AMH and medical history and give an accurate prediction of how many eggs I would expect from their ovaries if we were, for example, doing an egg freezing cycle or an IVF cycle, and then juxtapose that to how many eggs we know we need for someone that age. And that's that second part that most people don't get into with us sisters who go to clinics to freeze their eggs or to create embryos, especially when we're older or if we have a diminished ovarian reserve. And so I can't tell you how many times I meet like 40-year-old women who had one IVF cycle, 5 eggs were retrieved, and they're disappointed that the outcome was not a pregnancy. But the truth is 5 eggs at 40 is not enough eggs to actually get you to a live-born baby. And that's because of how eggs perform as they're older. Whereas if I have a 24-year-old and I got 5 eggs from her, I'm probably going to get 3 to 4 embryos for her from that.
I see. So you guys, I think what you really need to hear this here, and also there was a question from Love Blue Denim that I think we should read too, is that can you still have a great AMH and yet not a good quality? So we're going to answer that, but also you guys make sure you put your questions in the question box because we're going to put them up here on the screen. Dr. Duke is a pro at this, honey, and we try to get everything answered, but I don't want to miss something on a scroll.
Well,
but I think it's really important that you said that about the age. The age of when you're freezing the eggs is the egg will perform better the younger the egg is. So you guys need to hear that. So can you answer that question about the quality versus the quantity?
So let's start from Broken Brown Egg, who's just above. So my Broken Brown Egg said, my stupid PCOS had mine at 21, which is true. With PCOS, especially those who have that very resistant ovary that doesn't really ovulate, you're going to see just tons of eggs in there. And so an AMH of 21 isn't bad. For the purposes of fertility, we can actually get a lot of eggs from there, and we have to do very special medicines to make sure we really nurture those eggs so that when we actually do a retrieval, we're getting healthy, mature eggs. For a lot of places, unfortunately, they see that high number. The first thing they go in doing is they dose you really low, so you don't have a great response, but then even the quality of the eggs don't come out great. And really what we need is sort of a happy median, right? You need to get a decent number of eggs, but you need to use the right regimen to supplement those eggs to get them to that level of maturity. And so I see a lot of people, I know in the blogs online, I certainly have patients who come in and they're like, I was reading, I have PCOS, so I'm going to have really bad eggs and bad outcomes from my IVF. But the truth is, we have to take a special approach to your PCOS. And sometimes it requires more than one egg retrieval, even though you have such a high AMH, because the first cycle is actually going to prime and really plump up those eggs that are sitting there in the second pool, so that on the second retrieval, you get an even better, what we call cohort of eggs. So that's Broken Brown Egg. And then Love Blue Denim says, can you still have a great AMH and yet not good quality eggs? And that is actually dovetailing back to what Broken Brown Egg was mentioning. So yes, you can have a lot of eggs, but the quality of the eggs have an issue. The biggest determinant of egg quality is age. So, like I have some patients who are 45 and the AMH number is going to be the number that you see in someone who's 32. I mean, I have a 46-year-old. We did 3 egg retrievals from her, and each time we got 13 eggs, 46 years old. But every single one of those embryos was still chromosomally abnormal, because unfortunately, the biggest determinant of egg quality is their age, right? And remember, your eggs are still 4 months older than whatever your number is. No matter how amazing we look, our eggs are 4 months older. And
4 months older.
4 months older. Because your eggs form when you're about 20 weeks old in the belly, in the womb. And so, yes, that's the thing we have to remember. And it's why I love telling our Black and brown sisters, especially, and those born with ovaries, that we like to say black doesn't crack, brown doesn't frown. But the truth is our eggs are aging. And so we have to remember that. And so, yes, the younger you are, where you're able and financially able to get your eggs frozen, we recommend it, so that you have sort of that backup plan. Now, freezing your eggs doesn't mean you have to use them. So what Calais did is absolutely right. If you're thinking, maybe you're finding a partner, you just want to check in. Getting that egg number checked, getting your follicles checked is still the first step. Because even if someone came back to me at 42 and they had frozen eggs in their 30s, the first thing we're going to do is try to achieve pregnancy using the eggs they have now, especially if they're thinking they want more than one child. Because
Okay.
at 40, go ahead.
And I'm just going, because that's somewhere in my field, what you
Mm-hmm,
just said,
mm-hmm.
right? Now, so what a doctor may say to a woman of my age is try for 6 months, possibly
3 to 6 months.
3 to 6 months. And if not, we can then go to the next step of considering using the frozen eggs. So can you just briefly, can you answer two things? If a woman in her 40s, because I get this a lot in the DM, and I think sometimes people may not feel as encouraged to say this publicly, but they're still in their 40s and they maybe didn't freeze their eggs. They didn't know about the science. They didn't have the money at the time. And we say here on Warrior Wednesdays, and Dr. Duke, I know you amen this, throw yourself an egg shower, you guys.
Yes.
I am not just about baby showers, IVF showers, egg showers, all of the things to get the support. But for someone that may not have frozen their eggs, but still is hopeful for this, are there any foods or diets that you would suggest for women to be starting right now, whether they're in their 40s or not, to possibly boost their egg quality?
Yes.
Okay,
Yes.
so what would those be?
Well, I'm a huge proponent of eating healthy and also being very aware of your environment. And our environment is what we're putting on our bodies, meaning cosmetics, what we're putting into our body, meaning food and supplements, but also the larger environment. The truth is, I say this, climate justice is reproductive justice. And so every person who wants to become a parent one day, whether you have ovaries, whether you have testicles, whether you're supporting people who want to have children, you need to be very aware of what's happening in your climate, what's happening in your waterways, what's happening in your soil. But let's bring it home, closer to home to you. So in terms of food, I always say, if you're someone who's eating animal products, you want to be sure that you know where the animal products are being sourced from. Specifically, you want to be eating, if you're a meat eater, if you drink dairy or using dairy products, and poultry as well. If these came from animals that were raised in hormone-free, antibiotic-free environments, that's really, really important. Kelly, I've said this before on other appearances, but the truth is, antibiotics, which are used in animals, when we eat, they end up in our bodies. But those antibiotics, many of them act as hormones, or they interact with our hormonal system, and they're known as endocrine disruptors. So they can really reprogram or deprogram our own hormonal messaging. So that's a big deal.
They can reprogram or deprogram our own hormonal messaging. Y'all need to write that down?
Absolutely.
They can reprogram or deprogram our own hormonal messaging based off of the meat that you're eating and the hormones that they are fed.
Yeah, the meats and the milk, the butter, the dairy products. So again, I have no problems with people eating those things. I'm saying look into where it's sourced, right? The antibiotics have a whole separate issue, which is it can create antibiotic resistance in your body. And now if you ever have an infection, doctors are having a harder time finding an antibiotic that works for you, because through your food, you've become resistant to a lot of antibiotics. But that's a separate conversation. For the purpose of reproduction and your reproductive and hormonal health, absolutely. The other thing is actual chemicals and preservatives that get added to our food, that get added to our foods to help them have longer shelf lives, that get added to our food, meaning, so that they don't grow mold, so that they don't spoil quickly. All those things, actually, just think about that, right? It doesn't go into your body, though, and preserve your eggs. It actually, if your body is exposed to things that it doesn't know how to break them down, it looks for places to sequester them, places to store them. And unfortunately, one of the very hot places in our body where things get stored are all of our hormonal centers. So we have these, our hormonal headquarters, it's in the brain, right? Your pituitary. But then you have all these pit stops, the thyroid, your adrenal glands, your ovaries or your testicles, right? And so these are all places where things get sequestered. And so you can end up with a lot of toxic things getting stored, whether it be from microplastics, or it could be from certain chemicals like like BPA, which is bisphenol A, or phthalates, or polychlorinated biphenyls, which was one of the ingredients used for air conditioned units and stuff, but ended up in a lot of our waterways.
Wow.
And
Wow.
yes.
And you said microplastics, you guys. I hope that you really heard that. Don't heat your food up in plastic.
Yeah.
I mean, because that's what you're talking about. Those chemicals.
That's what we're talking about.
When you
and
heat up those lean cuisines, don't do that. Don't do that.
Take it out if you can, you know.
Yeah.
And here's the thing, right? It's not necessarily those companies' fault. Initially, plastic was touted as the greatest invention in the 40s and 50s. And certainly as a country where a lot of plastics were developed and designed, we marketed that the world over. The problem is small exposures here and there, that's not the issue. The issue is as we age, if you imagine you've been exposed to small doses of plastics and other inorganic materials that your body's absorbing but doesn't know how to break down, it's been storing, they're accumulating, right? They're accumulating. And so you couple that with the fact that your eggs are getting older, so they don't perform in the same way, and they're getting fewer, and you're going to get to a critical point where it's too much for you in terms of ovarian function or testicular function. And so while you can't go back in time, this isn't your parents' fault for believing in plastic. That's not the issue here at the moment. The issue is now that we've identified the issue, have you stopped it? Have you stopped getting it into your body? There's certainly some people working actively on research protocols to see what works, what might help decrease the microplastics and those different things. But the very first thing you can do is just stop adding.
Stop adding. Well,
stop adding to it.
Beautiful, so informative. I know everybody was writing that down. I'm going to go to the questions now, but while I do that, I just want to say that my mom wrote down that she did use your bok choy recipe the other day, and she
like it?
She did like it because she called me and told me. I want you guys to make sure you're following Dr. Cindy M. Duke. She puts information on her page all the time about healthy foods. I used your eggplant recipe and what that does for your eggs. And so she's constantly doing this. And like I said, also on Clubhouse with My Dynamic Uterus, you can hear Dr. Duke speaking so much about our menstrual cycle being vital signs and having a lot of these questions answered. So make sure you follow her here and follow her on Clubhouse. I'm going to go to the questions now because we have so many. Okay, so let's go here. Question: any thoughts about Ovasitol? Well, you know what that word is. I know. Ovasitol for PCOS. And can we tell everybody what PCOS is for those?
PCOS is polycystic ovary syndrome. It's a health condition that's very complex, and it actually presents in different ways in different people. And so, for example, you know, Kalei knows I'm on Clubhouse every Wednesday, including this morning. I do a room called Let's Talk PCOS Weekly. That's all we talk about in this room. Today it went for 2 hours, but that's because PCOS requires its own conversation. We can't even have the PCOS talk in the context of every other fertility issue, because PCOS literally affects you from head to toe, and it affects different people in different ways. And so while I love that we have more and more people advocating for PCOS because that's going to raise awareness, it's still important that each person learns what's going on in their body. So for PCOS, to diagnose it, and it's actually a diagnosis of exclusion, which means first we have to rule out all the other possible things that could be going on in your body before we say, hey, yeah, you have PCOS. That said, the rule out process does not take longer than 3 to 4 weeks, meaning one good visit, one good exam, and good blood draw, and that's enough. So I don't want anyone also feeling like it has to take 2 years, 3 years, which unfortunately is what happens. It takes too long for so many people, especially people of color, people coming from different cultures where going to see a gynecologist or a reproductive specialist has so much taboo that we have young teenagers struggling with PCOS, but they're not getting the care they need because their parents are like, I can't afford to let the people at the church or the temple hear that my teenager went to a gynecologist. They're going to assume she's now promiscuous, you know? And so there's all that fear and taboo. But PCOS really, it starts anywhere from your teens I have PCOS patients as young as 13 years old, and it persists even past your reproductive years, which is why I do this room, because I want PCOS patients to know this is a lifelong condition that can be controlled. Symptoms can be reversed, but you cannot live with your head in the sand like you don't have PCOS, and
So
you
let me
have to know it.
ask you a question really quick. I didn't mean to interrupt, but you
No,
said
that's
something
okay.
that kind of sparked something when you said I have patients that are 13 years old. For the people that are here, that are mothers, that are aunties, that are friends of young ones, what are the symptoms that we should be looking for? Because I had a mother reach out to me once and said, after a panel I did with Black Love on OWN about fertility, and said, I have 4 girls, and now I know much more to look for in them and their cycles, and whether or not their cycles are regular. Are they missing cycles? Because I think part of this is that we don't have the information to actually know what to look for our youth that we care about, we love, and we want to take care of. So what are the signs that we as we parent can look for someone that is young, that age, with PCOS or other underlying conditions?
Before I give the signs, I want to make one key caveat, which
Yes.
is once you start your first period, which is called menarche, it takes 2 years for your hormonal system to finish maturing. Meaning, however old someone is at first period, then it takes 2 years for things to regulate, for the body to finally figure out its rhythm, its menstrual rhythm.
2
So
years
what I'm
after
saying
your
here,
first
after
period.
first period, correct,
Okay,
which we
that was
call
Cherie
menarche.
Sims. Cherie Sims is the mom of 5. Hi, Cherie. So,
Hi, Cherie.
girl, put a question in there for your
Yes.
daughters. Yes.
And
Okay,
so the
2
reason why I
years.
say this is because I don't want unnecessary anxiety, and I don't want parents becoming hypervigilant while your child is still in their first 2 years following their period, because it can take a while for periods to come regularly, for the bleeding pattern to really get into its rhythm. So unless they're bleeding so heavy, where they're getting anemic or lightheaded, dizzy, passing out, or getting very pale in color, unless they're having severe pain with their periods, we will actually say, let's just watch it for 2 years, right?
Okay.
Because in terms of what I'm about to describe as the clinical signs of PCOS, some of this might just be you're in the first 2 years and it needs to regulate itself. But let's assume they're now past 2 years. So 2 years from first period. If they're continuing to have history of irregular periods, meaning their periods don't come on a regular basis, it's not predictable, it's not usually we say 21 to 35 days is the range. Certainly in a teenager, that range is more like 26 to 35 days. If your child is well outside of that range, where it's like every 60 days or no period at all, then someone needs to evaluate. Of course, we always make sure it's not pregnancy. And I know it's not your child, but we always make sure, because that would be really bad on my side if I missed a pregnancy.
Right.
So we have to make sure. But once we've ruled that out, then we look, so history of irregular periods. If the periods are irregular, then the first thing we check is, are the ovaries there still, and is the uterus there still? Why do I say that? Well, some of us are born with very tiny ovaries, or maybe only one ovary, and so that might run out of its eggs very quickly, and that might be the reason. And you would want to know that early, because if she's running out of eggs early, we might want to save some of her eggs, or their eggs, if they're non-binary, before they're out of that option for biological children. So that's something we check. Once we've established that ovaries and uterus are there, we make sure that there's a full connection and nothing's blocking the flow of blood out of the uterus, and that blood isn't sort of backing up into the womb. Once that's clear, the next question is, do they have acne? Do they have any evidence of what we call androgen or testosterone hormone excess? So that's based on blood work and or evidence of acne on the face, chest, back, lower abdomen, or inner thigh. Yeah, there are people who have acne in the upper inner thigh and lower groin area. Or do they have excess or unwanted hair growth on the face, chest, back, lower abdomen, upper inner thigh? Also, we usually look not just hair growth, but is there evidence of hair loss in sort of that pattern, female
Thinning.
pattern, where it's thinning. And so they're not necessarily going bald, but you can actually see more of their scalp because the follicle density is decreasing. And then third, on ultrasound, if they're virginal, then we do a transabdominal ultrasound, meaning an ultrasound over their belly, and we count how many egg houses are in the ovary. Key point and key takeaway. Although we call it polycystic ovary syndrome, we're really not looking for cysts. We're looking for tiny egg houses known as follicles. It really should be PFOS, which is polyfollicular ovary syndrome, because that's what we're looking for. Lots of follicles, the tiny egg houses measuring less than 10 millimeters. We're not looking for big cysts. And unfortunately, there's a lot of misinformation out there that leads people to think, oh, they found a cyst on my ovary, or the doctor said they found 2 cysts. That's polycystic. That's not it. We're still working on making sure all clinicians have the right definition for PCOS and understand how to diagnose it. If you notice, though, those are the 3 criteria I listed. At no point did I say it's based on weight. At no point did I say it was based on whether you have sugar problems or not. It's not based on those.
Wow. Woo! Listen, you guys, the playback of this is amazing. Did we answer the question about the medication, about the Ovactol?
Right, so in Ovactol. So Ovactol is a brand by Virologist, is a company that makes Ovactol. But Ovactol contains Myonosatol, which is the name of the ingredient. So Myonosatol is one of those supplements that plays a role in glucose metabolism. Specifically, it helps your muscles, which are your muscle cells are known as myocytes, hence the word myo. And so it works on your muscle cells in terms of how they metabolize sugar, how they pick up sugar from your bloodstream. I like to describe myonositol as sort of nature's version of what we see in metformin, except metformin is very concentrated and higher dose. So in patients, particularly PCOS patients who have insulin insensitivity or some glucose dysmetabolism, and I'll explain that in a second. Doesn't mean you have to be pre-diabetic. It means I have to see on testing that your body actually has to do extra work to process sugar, even if your sugars are normal, but it's working harder. Myonositol will help. And it helps even at the level of the ovary, because your ovaries need energy. They need energy to process follicles and get eggs matured in any month. And so it helps with that. And so myonositol is helpful in particularly PCOS patients. Right now, almost everybody is coming in on myonositol. Really, most people don't need it. It's specific for those who have PCOS, and not just every PCOS either. It's really for the ones that have glucose dysmetabolism. And so how do we measure that? Well, I know there are primary care doctors and gynecologists who measure like your hemoglobin A1C. They're looking to see if your A1C is elevated. Most younger PCOS patients, their A1C is still going to be normal. But what we actually do is a 2-hour glucose tolerance test with an insulin response. Because what we're really looking to see is if we gave you something very sweet, which is 75 grams of glucose, how hard does your body have to work to keep your sugars normal? Yeah, because in a younger person, your pancreas is still healthy enough. It's going to rise to the challenge and take care of all that sugar you took in. But the question is, how hard did it have to work to do that? And that's what that test helps me figure out. And so in someone like that, myonositol is helpful. Certainly, you don't need to see a doctor to get myonositol. It's over the counter. It's a supplement. Okay. But certainly, if it's not working for you, it's probably because you're not the candidate for it.
I see. Okay. Now you did it again, Dr. Duke. Let me go to another question because there's so many here. I love it. All right. Here we go. Someone asks here, is it possible to get eggs from one ovary? I had a partial hysterectomy and had one ovary taken. Is it possible to get eggs from one ovary?
Yeah, so I have patients who've had hysterectomy for chronic pelvic pain or whatever the reason. Maybe they thought they'd never wanted children, and then they met a life partner, and now the whole picture's changed. And so we go ahead, and if they have an ovary remaining, yep, we can get eggs from that ovary. So I have patients as long as you haven't gone through natural menopause. I mean, the age thing still matters. How old your ovary is, how old those eggs in the ovary happen to be, still matters. But if you happen to have eggs, you're still at that age where we can get viable eggs. Absolutely. An absent uterus does not prevent that. By the way, there are people who are born without a uterus. That's called
Yes.
MRKH. Yes.
MRKHH.
Correct.
MRKH. And we
Mm-hmm.
had a wonderful young poet
Yes.
who was diagnosed with MRKH. Her name is Stacy on Warrior Wednesdays, you
Mm-hmm.
guys. You
Mm-hmm.
guys can watch her episode on warrior-wednesdays.com. You can also see
Yes.
all of Dr. Duke's episodes. You can also look at it here on IGTV. But we had Stacy, and she did a beautiful poem, and all of the warriors in the comment section made a
Mm-hmm.
poem for her. And she was also part of Resolve's National Infertility Awareness Week. So beautiful, beautiful thing.
Mm-hmm.
And we have to learn about these conditions because these are the things that we don't know, whether it's MRKH or
Mm-hmm.
bicornuate uterus.
Bicornuate uterus, unicornuate uterus. There are
Yes.
people born without ovaries. So they have a uterus, but no ovaries. You know, the truth is reproduction, in terms of our reproductive development, there's a spectrum. And we've known this all the time in the world of reproductive endocrine. We've known it in pediatrics and pediatric endocrine. We never quite told the rest of the world. And that's why the world is now so fixated on the heteronormative, cisgender, man, woman. But the truth is, we've always known that gender was a spectrum, and we know that sexual development is a spectrum as well.
Mm-hmm.
We've always known this, and I see it. You know, this year alone, I've diagnosed three young girls, all African American, by the way, with MRKH here in Las Vegas. 3 this year, which is not easy. It's not easy telling a 14-year-old she doesn't have a uterus and explain what that means to her, but also to her mom, who fortunately is young enough but might have to be the one to carry her own grandbabies in the future. You know, it's not easy though, having that conversation, breaking that news to someone as young as 14. Bicornuate. I had a 16-year-old this year that I diagnosed with a unicornuate uterus, meaning she has one horn of her womb cavity, the other horn didn't really form. And so what does that mean? But it's really important that we know these things and we recognize, but also we understand it so we don't use language that hurts unintentionally, right?
This is why, you guys, this is why I wait on Dr. Cindy M. Duke. This is why. Okay, I'm going to go to the next question. We want to be able to serve you as much as we can. Let's see here. Have you heard if whether or not the COVID vaccine affects pregnancy? It's a very important question living in this age of COVID. Have you heard whether or not the COVID vaccine affects pregnancy? Well, you're speaking to a virologist here, a virologist. I say it a different way, but the only dual fertility specialist and virologist is right here on live, you guys. She has studied viruses and she knows. So
I've studied viruses, vaccine development. Actually, the COVID vaccines are safe and very much recommended in pregnancy, and they actually improve your pregnancy outcomes if you compare to what happens if you're exposed to COVID and weren't vaccinated. But before we jump to pregnancy, I think this is a perfect opportunity to also address what we've been seeing in the media and social media about vaccines and periods. And so, yes, people will have some changes in their periods for that month or the month following the vaccine, depending on when you got the vaccine, when in your menstrual cycle. And so it's not uncommon, but the change in your period, it's temporary. It makes sense. It happens if you got an infection, so not a vaccine, and your body was mounting an immune response. We see similar things. It's also what happens if certain things are in your body to fight an infection. So for example, most of you who've been on birth control, particularly if you're on a birth control pill, you probably remember a doctor prescribing you an antibiotic when you've had an infection, and the doctor saying, while you're using this antibiotic and for 2 weeks, 3 weeks after, use extra birth control or avoid sex if you don't want to get pregnant.
Because it counteracts it, right?
It counteracts, and it's the same thing. And so I know there are lots of people out there who are using these opportunities to stoke fear, to scare you about vaccination, but trust and believe vaccines are helpful. Another group of people that we now have clear data showing that they are at higher risk of COVID-19 poor outcomes are PCOS patients. And it doesn't surprise me entirely because we know PCOS has an inflammatory picture to it, Calais. We know PCOS can affect how some people metabolize glucose and so forth. It can impact your kidney function, etc. And now we have clear data that shows PCOS patients 20 to 30% more likely to have negative outcomes from COVID-19 if they become infected with SARS-CoV-2. So if you're PCOS, get your vaccine, protect your health, protect your future. Now, pregnancy. We actually have full data, full research data that's looking at how people who got vaccinated and then were pregnant or became pregnant, how they did. There's no increased rate of pregnancy loss. No increased rates of pregnancy loss. In fact,
write it down, y'all.
Yeah, so no miscarriage, no stillbirth related to vaccines. That is very different from the up to 6-fold increase we're seeing in stillbirth in women who were pregnant and got sick with COVID-19.
That were not vaccinated.
Not vaccinated. Excuse me. And so that's really big deal, right? We're seeing that in Black and brown women who got COVID-19 while pregnant. We saw more poor health outcomes for mom, but also poor outcomes for baby. Some of it is preterm delivery, and with prematurity comes just different things as they relate to lung development, eye development, intestinal development for the baby. But we also saw higher rates of heart attack, myocardial infarction in these moms that are otherwise young. Some of them could be healthier. Some of them had weight issues. Some of them had PCOS. Some had diabetes or
but
gestational
COVID is
diabetes.
A multi-organ disease, and I think that's what people don't really understand because we heard that it's a respiratory disease. We've heard about the lungs. I'm asthmatic, so I got extra scared. But what we really didn't hear is that it affects multi-systems.
Exactly. And so imagine if you have PCOS underlying, which also impacts multiple organs in your body to begin with.
Right. And then
imagine if you have high blood pressure. Imagine if you have an autoimmune disease that already, maybe because of the medications they have you on, your immune system is somewhat compromised. You need your vaccine so you can have that first line of defense. Now, specific to those who are in the 3rd trimester and those who are delivering, we know that getting vaccinated in your 3rd trimester allows your body to not only make antibodies that protects you while you're pregnant, but those antibodies can cross the placenta and they become your baby's antibodies for their first 6 months of life. And so getting vaccinated while you're pregnant is not only protecting you, but you're actually, if you're looking forward, you're protecting your baby for the first 3 to 6 months of life post-delivery. Similarly, if you're breastfeeding or if you're pumping milk, because you don't necessarily have to breastfeed to get breast milk into your baby. You can pump and bottle feed, etc. You're still going to get all the antibodies to your baby. That is also another way to get good antibodies, but also T cells that further protects your baby. And think of it that way, because that's the way it works. That was how nature intended it, which is babies' immune systems aren't mature for the first 6 months of life, but they are born with a strong immune system because of what they got that crossed the placenta.
I love that you said that. And I love, before we go to the next question, I just want to reiterate, if you can reiterate when you said T cells, and now I now understand. I did a live with Dr. Duke that was specifically about COVID and the COVID vaccines. Like I said, she studies viruses, okay? The only dual fertility specialist and virologist out there you are listening to here live. You can see that episode on warrior-wednesdays.com. But what I learned is what the true goal of a vaccine is. Most people think that a vaccine means I won't catch COVID. Can you please just briefly explain what a vaccine is, what its goal is, and how it works?
Yes. So when we're vaccinating against viruses, our primary goal isn't to prevent infection, which is another key point of misinformation that's out there. Is there people saying, well, it's not preventing infection, why are you going to take it? No. The goal of a vaccine is to prepare your immune system so that if you were to become exposed to the virus, you recognize it early, you fight it off early, clear the infection early so that you don't get very sick. one. Second is if you can clear it early, you can also decrease your transmission of that virus. And yes, studies have shown very clearly in the context of COVID. Look, I was expecting this, and I've been telling people this, but we actually have COVID specific data now, because there are people like, well, how do you know it's going to be the same for COVID? It is, which is, there's clear data that shows that people who have been vaccinated and then got infected, clear the infection sooner, but they're also less likely to transmit. And that's because they're not shedding virus for as long and not as much virus, because their immune system is taking care of it. And that's the goal of vaccines. And as I shared in that episode, I shared the history of how vaccines came about, and even why the word is called vaccine, which it's from the Latin word for cow, which is vacca. And it all has to do with cowpox. All this goes back to cowpox, which is, there was a doctor in England who noticed that while smallpox was ravaging the world, and believe me, it was. Smallpox is one of the viral infections that wiped out the Aztecs, wiped out tremendous populations of Native Americans, because it was a virus they had never seen, kind of like how we had never seen SARS-CoV-2 before. And so it ran through their population and decimated them. But it was also rampant in Europe and causing lots of deaths and deformities. And he noticed something. He was astute, and he realized that milkmaids, young women who milked cows, even if they got smallpox, never got very sick. And he was wondering, why is that? How come they don't get very sick? And he realizes because cows have their own version of the pox, known as cowpox, or we now call it vaccinia. That's the name of that virus, vaccinia. And he realized that, maybe they're getting a mild form of that cowpox. And if they got sick, then they now have immunity. They have memory for seeing that virus. So when they're exposed to the human form, which is smallpox, they don't get that sick. And that's literally how the first vaccinations happened. He realized that if he took their blood, he realized they have immunity. And so they started by vaccinating people with a weakened version of the pox, which is the cowpox. That's how that started. And hence the word vaccine. The word herd immunity comes from thinking of a herd of cows. If you can get as many people to get the herd, then, and so that's what our vaccine is for. People were erroneously applying herd immunity to the infection because they didn't understand. But vaccines are how you get the most effective herd immunity. And so fortunately, guys, here's the good news, right? To date, 63% of Americans have had at least one dose of a COVID vaccine, of American adults, 63%. Over 50% have had their 2 doses. We still need more adults to get vaccinated. We certainly now need to get more of our 12-year-olds and older vaccinated, and they're still working on the data for under 12. And the data isn't whether it's going to be effective in kids under 12, is we just need to figure out the dose for kids under 12. And so, you know, we work by science. We don't just jump and give people medicines, which, by the way, is a big difference compared to, say, 60 years ago. Right? Yes. And so, but it's important. It's important. I know in the US, like I said in that show, many of us haven't seen the things that we get vaccinated for and how negatively they can impact communities. In the US, every now and then we hear about a measles outbreak, but we don't really realize that 200,000 children outside of the US still die from measles infection every year because they don't have access to vaccines. Wow. There are still children the world over who are struggling with poliomyelitis, which is another virus that leads to the killing of the nucleus of your nerve cells that go to your muscles. And it leads to those muscles shriveling up, so to speak. And so you lose function. You know, Calais, I went to Mexico a few weeks ago. Yes. And it broke my heart. We were in one of the small towns just checking things out and touring, because I love going to the small towns just to see how life is working. And I saw a little girl with clearly what was polio, and it broke my heart, because here in the US, we don't even give polio vaccines anymore unless someone's traveling to certain countries where polio is still endemic. And that's because we have effectively used vaccines to eliminate the threat of polio in our country. But as a result, people who have never seen it now don't realize that it's a big deal. And lastly, I just want to say, so you guys understand how everything ties in together. Because of polio and just how debilitating it was, which is it could paralyze muscles for good, we had to develop the iron lung, which is really the predated version of the ventilator. And so polio was what led to all of that science that really gave us a lot of what we now call modern day ventilators, that of course became the mainstay for helping to keep people alive who got COVID. Think about that.
Floored. I always am. And because here's the thing, and this is what you do so miraculously, is you make this information and this history so accessible and understandable to all of us that do not have a medical degree. And once you hear this, and it can make sense that 1 + 1 = 2, and the history of how we've created things like ventilators that were from the iron lung that was needed because of polio, and then we have the vaccine, and then it all connects, because there is so much misinformation. There's so much fear. I remember when I went to Africa, when I went to Ghana, I had no problem going in there and getting my yellow fever vaccine.
Yes.
There's things that you have to do, or they won't let you enter the continent. And you just go and you're like, yeah, so I can get on the plane. But then we have the situation here, and everything gets discombobulated. So I just want to say thank you, because just having that very thoughtful and mindful information automatically empowers us to make the proper choices and to stay away from all of the theories and all of the conspiracies out there that are not helping our community. So you guys, this is why I say share this live, go to Warrior-Wednesdays, follow Dr. Duke, because this is the information you need. So I'm going to keep doing these questions here. Let's see.
You know, Kelly, this Friday, I'm going to be 6 months fully vaccinated. That's how long since I received my second dose of the Pfizer vaccine on the 11th of June.
You and Mama Stu are going to celebrate together and have a little party.
We should, Mama Stu. I'll cook bok choy.
Exactly. Cherise Sims, that's our mother of 5 who is asking questions. Are there any stats about premieres and future eggs? Is that preemies? Or is it premiere and future eggs if born shortly after 20 weeks when... let me see, Cherise. I don't know if I'm asking the right question. Are there any stats about, it says premieres and future eggs?
Yeah, I think I
shortly after 20 weeks.
She probably heard me say that our eggs form at around 20 weeks. And so the truth is, it hasn't been studied yet. There are people doing it, though. I happen to be involved because we just want to know. We happen to know preemies go on to have babies. They go on to have children of their own. So clearly they have enough. But whether or not that impacts their AMH levels at all, we don't know, because while we've been collecting blood on preemies, obviously they get a lot of blood drawn. No one was studying that specific aspect yet, but there are repositories that still have a lot of that blood, and so now we're looking to see, can we do that? It depends on how the blood was stored. AMH has to be processed in a special way, but the short answer is we don't have an answer as to a specific answer, but I would say extrapolating, preemies have now grown up and have children. So we know they have kids.
We know they do. Mama Stu says, wow, I am old enough to remember I got the polio vaccine. Well, I'm glad you did, Mama Stu. I'm glad you did. So she says here, we have a question from We Us It Thoughts. Thoughts on soy and how it impacts reproduction health in adults and children. Thoughts on soy.
So soy is an interesting one. There's soy that we have derived from our mass farming in the US. And then there are parts of the world where soy is still very much farmed in the way it was farmed 1,000 years ago, 2,000 years ago. Some of our soy in the United States is genetically modified. I point that out because we're probably one of the few countries in terms of developed countries in the world where there isn't a whole lot of regulation on how some of that modification happens. And the data on that is mixed. But my point is soy has become an allergen for a lot of people in terms of allergic responses or eliciting an inflammatory response in your body. And so that can change how your body then absorbs other things. You know, the largest immune interface on your body is your skin, right? This is our biggest immune defense. Most people don't realize that. Our second largest immune defense is within our gut, right? From the moment you put something in your mouth until it transits all the way through to the anus, that's constant exposure, and there's an immune system sitting underneath within the tissue there, also fighting things off, interacting with your microbiome, the bacteria and other microbes in your gut, the same on your skin, right? We are one individual, but we have about 10 billion colonies between our face, our skin, and our gut, vagina, anus. There's a lot of bacteria and microbes on us. Most people don't know this. But
There's a lot going on.
But they're necessary because they help, one, to educate our immune system in the gut, one. Two, they also help to prime our inflammatory system, which then dictates how your hormones respond and how your brain keeps you healthy. And so what we're learning more and more is some of these foods, their allergic profile changes, or what we call the antigens shift depending on the modifications, and we may see more immune responses to them here in the US. So, for example, it's not uncommon to meet someone who can't really eat soy in the US, but then they'll tell you they spent a time in a certain part of the world, usually Asia, and they had no issue with soy there. And that's because of how it's processed, or in terms of the actual type of soy that's grown. So that's the first. The second is soy. Yes, some soys have weak forms of what we call phytoestrogens that might be stimulating certain aspects of our hormonal system independent from inflammation. But the data on that is mixed, because we've actually looked, and you'd have to eat a whole lot of soy. And so if you're vegan, yes, for a lot of people who are vegan, a lot of their full meat products are soy-based. So I encourage my patients to mix it up. Even though you're vegan, meaning you don't eat any animal products, really try to find different sources and don't just rely on soy as your protein source. And, you know, if you can eat fish, if you're big about the ethical use of animals and stuff, which is, again, for some people, it ties right into climate justice and reproductive justice, then figuring out ethical ways to get protein, even fish protein, is going to be important. But soy in and of itself, by itself, doesn't lead to infertility, but it can lead to allergic responses in children, and we see that in babies, and we see some babies who cannot take soy-based formula or food, and we see it in adults. But we also notice that what triggers someone's response in one country, they go to another part of the world where these foods are farmed and processed differently, and suddenly they don't have a problem.
Wow. Very interesting. That's me. Cheryl says the same thing. Yes, the way that it is farmed. So we're just going to look at a couple more questions, Dr. Duke, before we let you go.
That's okay. I have time.
Oh, wow. I love it. Okay, let's see here. Here says, well, that's the person I just called out. Do you suggest to women to wait until they have a mate to have a baby? Do you suggest to women to wait until they have a mate to have a baby? I'm going to answer too,
Girl,
Dr.
no.
Duke. Shall no.
No.
Wait,
no.
Duke,
I'm
gonna
a
get
huge
right up.
proponent.
I'm gonna get right
Yes.
up on here. Shall
No.
Not if you want to. If you want a baby, and if you're not ready, I'll say this. Gave me a sense of encouragement. When I froze my eggs when I was 37, I understand I'm freezing my potential fertility, right? Because those eggs have to survive being frozen. They have to survive being made into embryos and implantation and all of those things. And before Dr. Duke answers, I'm just going to say this. What I will say about freezing my eggs, because I do want to wait for the right person before I start my family, is I dated differently. So whether you're dating people with ovaries or whether you're dating people with sperm or whatever the case may be, what I learned is if that person did not qualify for me to co-parent a child with me, the dating, the process of it was easy breezy. I didn't take things personally anymore. I didn't stay longer than the expiration date of that relationship. I didn't put too much in, because I knew I have a goal to be a mother. And if you don't match that goal, I don't take it personally. I just don't waste my time. So there was something very liberating and and about freezing my eggs and knowing that now I'm dating with purpose and not because I'm bored or because I am lonely. So that would be my suggestion.
Or because you feel a sense of desperation
or
because your eggs are
desperation.
aging.
Yes, yes. Can you, and what's your answer to that question, unless you want to aim
I
it?
agree wholeheartedly, and I meet those patients all the time. I have patients, I mean, we have one who sends us pictures and she's like, you know, just sending it for the baby daddies to see, meaning the clinic, but we laugh, right? But it's not becoming single parents by choice. We currently have a single dad by choice who's going through, and you know, we're actually starting the surrogacy process next week. We've already created the embryos. He purchased his egg donors. He used his sperm, created embryos. We got them tested. Now we're about to get ready for transfer. So no,
Dr. Duke, you can give him my number too if you want.
right? Yes, no, and
I love that.
By the way, we're seeing more and more guys, including very successful guys, doing this, right? I mean, if we think of our world's most successful soccer player, Cristiano Ronaldo, even before he met his current spouse, he went ahead and went that route with his first couple children. Hill Harper did it too. Absolutely.
Yes.
And that's another thing we need to normalize in the conversation, because there are people out there who, Father's Day is coming. Most people don't realize you can be a single dad, or that there are guys who are choosing to become single dads by choice. And I know there are people out there who are like, well, that's just selfish. There are so many people out there they could partner with. And no, it's a choice. Similarly, there are those who are like, oh, he must be in the closet. Not really. I really think it's a personal choice. And just like how I have my single moms by choice who come through the office, and we support them through, we get them all the help they need to make their decision. I won't lie to you, it's not easy. Actually, I'm going to get one of our single moms by choice. She said she'll do a live with me and we'll talk about it. You know,
yes, I'll be watching.
Yes, I'll definitely promote, because she wants to share it. And her little guy, you know, at this point, he's going to be 4 soon, and he's as cute as pie. But, you know, she shared openly before that it's not easy. You know, she still has embryos frozen, but hasn't elected to go forward with adding another child to the family, because she's like, Dr. Duke, it's a lot of work, and it's just me. And well, her mom helps out too. You know, mom helps out maybe extra because mom loves her grandson. But you know, so it's not easy, but it is something that people do. I think it's a personal choice. I would say, as a fertility physician, my job is to facilitate every dream. Meaning, I also have patients who have come in to become egg donors but have no desire to have a child of their own. But they want someone who is looking to build a family to be able to have access to eggs like theirs to build their families.
Can we pause right there, because this is really important, especially with African American, brown, and you know, your mocha patients. Because when I froze my eggs, and I'll just let you guys know, the clinic gives me the option that should I not want to use my eggs for myself, would I like to donate? And what I hear a lot, especially in the African American community, is the lack of African American egg donors and eggs that are available. Can you speak to that a little bit in terms of what you know about any agencies or places where people of color can maybe find, you know, that would like a child that is of their same culture?
Well, certainly we do a lot of that at Nevada Fertility Institute, but we are an egg production center for My Egg Bank. It's called My Egg Bank. So not Dr. Cindy's Egg Bank. The company is My Egg Bank, MEB. But we also work with agencies. With agencies, that's where you're looking to find a donor who hasn't had her eggs retrieved yet in terms of what's available to you. And usually they find a match. The way you match for a donor, whether you're using an egg bank or you're going through an agency, is usually we recommend you find someone who looks an awful lot like you. So typically, if it's a person who's going to carry their own pregnancy, you're looking for someone whose photos as a child, and typically you're seeing photos of them as a toddler and photos of them as a preteen. Because believe it or not, the biggest predictor of resemblance is how you look like as a child, right?
Wow.
In part because a lot of us have also modified our features as we aged. And so you can't really base predictability of how they're going to look on how they look today, right? But you can look at how they looked as a child and preteen and compare that to your own photo. That said, there are a lot more donors available. So like my egg bank, actually, they started in Atlanta. Their home base is in Atlanta. And so they have a lot of African-American Black donors, including donors coming from, Ethiopia and different, I use as an example, but different places within Africa, different parts of the Caribbean. But there are 5 other egg banks in the US. So when my patients are looking, we have them look at all the egg banks, right?
Okay.
If they're not finding, then we usually go to the agency so they can go through a fresh egg donation. But it's more than doable. I think the biggest issue I see when it comes to egg donation, we're finally coming to a point where we see more young women volunteering to be donors. They're compensated, but it's still them choosing to donate their eggs. But what we still see is that there are huge amounts of taboo around the idea of using donated eggs to create your own pregnancy and build your family. And so we still have to do a lot of work around educating our communities, educating people about family building, educating people about the programming that actually happens when an embryo is growing in a womb, and how that womb and the person carrying the baby is going to be programming based on what you eat, based on the emotions you're feeling, the stress you're exposed to, if you have diabetes, etc., how that primes that child for the future. But I really think one is we need to bring that conversation more to the fore. We need to normalize it so that people don't feel weird and people don't feel lost. The truth is, if you really think about it, in African American and Brown communities, we essentially are family members who have been struggling with infertility historically. You think back and so was grown by auntie this, or they grew up with auntie that because she or they took you in because they didn't have kids of their own. That usually was your family member who was also struggling with infertility, but we didn't talk about it, right? And so we just need to start normalizing it. One, so that those people like our aunties, who might now be the same auntie at church who's judging the younger person with infertility, is to help her come forth with her own story and normalize it so she can share and actually motivate the new generation.
Every part of that answer I love, and I do think that I agree with you so much that we need to normalize it, especially because one of the things that we have to be very mindful of is not shaming people because they don't have a baby yet, not like, intruding on their privacy, asking them those questions that are invasive and triggering. And one of the things that I always say here, and I think that it's about educating other women, is that 99.9% of the women that ask me questions about when you're going to defrost them eggs and do you think you're going to use a friend's sperm is always another woman. Yes. And a lot of the times it's a woman that already has children. So she'll never understand the consequences of the answer of the question she's asking me. Correct. And so I think one of the things that I've been learning to do is stand up for myself, but to also, hey, honey, ain't none of your business, that kind of thing, especially over the Thanksgiving dinner. You know what I mean? It's just not. But also to educate other women in a compassionate way to say, hey, I know you're well-meaning, but it's actually triggering, it's invasive, it's hurtful, and you have three kids running around, which is exactly what I'm hoping for. And so please be mindful of that before you speak to me or anybody else about their life choices. So I think that we need to definitely do that. And also, I just want to mention that Broken Brown Egg brought up Eloise Drake from Family Inceptions, and she's an African-American woman. She was a gestational carrier, and talks about donor eggs. And I have actually reached out to her. She's going to be doing a Warriors one of these days soon. So we will also be speaking to Eloise about donor eggs. So just a few more questions here.
So Eloise is a great one. And then I do have someone, if you want to talk to a surrogate, a gestational carrier. She loves talking about that as well. A Black woman who has done it twice. And yeah, she just loves it. And I think it's important. I love what you said there, Calais, because I think most people don't realize that respecting someone's privacy is showing them grace, right? That is
Ooh.
really important. If you can respect someone's privacy, that is the best grace you can show them. And it's so important because we just make judgments, and we make judgmental comments without even realizing it. You know, I remember I was somewhere and someone asked, "Do you have kids?" And I said no, and they're like, "And this is your clinic?" And I said yes, and they're like, "Oh, it must be nice not to have responsibility." I was like, where did you go from no kids to me not having responsibility in my life? That's not true. But yet people use language like that all the time. We use language like we see people who are married and they don't have children, and we assume they're being selfish, right? I've heard people say, "You're just being selfish not having kids," without knowing what they've been going through, not knowing how many times they've already probably lost pregnancies, or maybe they have been on their adoption journey. They may have even received a baby as part of their adoption, and then the birth parent changed their mind and the adoption had to be reversed. You really don't know what people are going through. You don't know how many people may have left for a vacation, but they really went to seek out fertility care and came back from vacation heartbroken. So then you see them, you're like, "Oh, I envy you. Look at you. You look so tan. You look amazing. You're just living the life. I'm over here with my 2 kids struggling." And the truth is, you're actually now rubbing salt in their wound, because their vacation was actually either a trip for adoption or a trip for fertility treatments, and you just smacked them in the face.
And this is this is the thing, because this is why we suffer in silence. Because our pain is optional. Our pain is inevitable. Our suffering is optional. Because the thing is, when we're triggered over and over and over again, of course you're going to retreat and not want to talk about it. When we're told that infertility means I'm broken or I'm a failure, my body doesn't work, of course you're going to come back and retreat. And so these are the reasons, normalizing these conversations.
Correct.
Letting other men and women know you are part of a large group of amazingly resilient and strong people, y'all. These infertility streets are full of the best people I have ever met in my life.
Very strong.
To be very strong. I'm honored to be in this group, and there is nothing for us to be ashamed of. And don't let anybody trigger you. My mother said, and she probably would do this for you too, she said, "Unfortunately, I pop off when I'm asked about my daughter." Yes, she does. And she would pop off if she was asked about Dr. Sidney Duke's responsibility.
Yes, please. Well, you know, my mom recently, one of the assistants sent me something, because, you know, I guess my mom does comment on politics in our home country liberally. And so, of course, with that, you're going to, as we say, mash a few corns. And so somebody who felt fired up over who they support politically sent her messages like, you know, "Do you have any grandchildren yet? Where are your grandchildren?" Because again, right, that's sort of that cultural thing. And that's how they sort of, you know, point daggers at older women. And my mom wrote back, you know, "Have you stopped cheating on your husband?"
Mama Duke, is Mama Duke here today?
I was like, "Mama," she was like, "Well, she was trying to hurt me. I just answered the way she wanted an answer." And I was like, "Oh my God." But, you know, really, that's what people do. And in cultures, that's how people think they can hurt you, right? That's the way they can, if they don't know that you're enlightened enough, they're going to try to throw those daggers, meaning that's how they're going to cut you down.
Your mom and my mom are kindred sisters and spirits. And, you know, because my mom has said that she has reached the age where she's going to say exactly what's on her mind.
Exactly.
You come from my child, you're going to get the whole thing. And yes, we culturally, sometimes religiously, you know, we find all different excuses to cut somebody down. But I absolutely just want to commend you. And I love what you said. Respecting someone's privacy is the best way to give grace. Yes. And I think that is beautiful. And I'm glad we even touched on this part of this trigger, this emotional part of it, because we all need to feel empowered to speak our truth. And listen, you guys, and this is the last thing I'll say on this topic, and we'll go to another question really quick, is that not everybody gets to know your fertility journey.
Correct.
You have to be very, you know, I feel like we need to normalize it, but we also need to normalize knowing who to trust with this space in you, because it's very vulnerable. It's very scary. It has a lot of heartache and heartbreak attached to it. And you need to make sure that you're sharing it with people that are going to pray for you. You're sharing it with people that are going to speak into your listening, that are encouraging. If you know somebody is judgy, if you know somebody is nosy or a gossip, don't tell them. Use the beautiful gift of your discernment to find your tribe. And trust me, I have found it here right in this comment section, to find your tribe of people that you can confide in. Because we, like I said, the fertility community has a lot of wonderful people that understand because they're walking the same walk that you are. So I'm going to go here to another question here. Let's see.
I mean, just remember, right, when you're looking to confide in people, not everyone's worked through their toxic history. So some of them, they're prone to toxicity without even realizing. Like, they really want to be good people, but they haven't worked through their toxic history.
Haven't worked through their stuff.
So they're just toxic. They're toxic even to you, although they want to be your friend. And it's your job to identify that person.
You have to identify that, discern that, watch their behavior. And if it doesn't look like you or feel like, you know, a good thing, don't follow it, you know? Okay, so, and She Shall Reign asks, why don't most OBs like doing unmonitored Clomid? Unmonitored Clomid.
I actually think the obstetricians, the general OB-GYNs are the ones who do unmonitored. Fertility specialists, no. Yeah, I'm not doing an unmonitored Clomid cycle. I'm sorry. I don't do that. I need information, one. There are some of the OB-GYNs, the general OB-GYNs, who also don't do it because, you know, unmonitored Clomid is when we see the natural octuplets on TV and people are like, oh no, I didn't use anything. Yeah, they took Clomid. Nobody's making 10 babies naturally. And by the way, the word natural I don't like, but nobody's making 10 babies unassisted, okay? That's happening because of medicine. But the reason why is there are risks, right? So you can have ovarian hyperstimulation syndrome even on Clomid, and especially if you didn't take the dosing right. So if we're not monitoring to actually see what happens, you could find yourself with a DVT. You can be landed in the hospital in the intensive care unit. That's worst case scenario. I mean, death is worst case scenario, but landing in the ICU is the most likely worst case scenario. There's that. But then the other risks are, yeah, you could end up releasing 3, 4, 5, 6, 7 eggs, and that becomes a very high risk pregnancy if you're pregnant with multiples. In some places, that can bring the doctor under censure. They can lose their medical license. So there's a true liability to them and their ability to continue to practice. If indeed the patient ends up saying, nobody told me that I could end up pregnant with 4 babies. Well, even though it's unmonitored, that's what comes up in court. And now this doctor is having to spend a lot of money defending themselves. So again, we don't do unmonitored cycles. It's not because we're trying to hold purse strings or force you to spend money, but there is risk. That said, there are doctors who do unmonitored Clomid cycle. They're generally the OB-GYNs, the generalists, and they'll usually do it for low dose Clomid. So 50 milligrams, which is 1 tablet, or two tablets, which is 100 milligrams. Beyond that, they will then tell you you need to come in to get monitored. I know there are blogs out there where people are touting that you don't need it, and they're telling you go to other countries and buy Clomid yourself, etc. I don't recommend it. Again, these things do not come without risk. Just remember that. And the last thing you want is to face your risk when you're losing your ovaries because it's twisted because of a torsion or something because it got so big, or you're in the hospital and fighting for your life, when it could have been easily prevented with monitoring.
Wow. Okay. I want to ask a really quick question because I saw it scroll. Yeast infections. We've never talked about yeast infections here at Warrior Wednesdays. That there was a question, do reoccurrent yeast infections, can that have an effect on fertility? I think I know the answer to it, but can you just explain for those what a yeast infection is and what the process of curing them are, and reoccurrent ones especially?
So yeast infections are really the result of a shift in vaginal pH that leads to an overgrowth of different fungal species known as Candida. So Candida is this actual genus, and then you have different types of Candida that can grow in the vagina. And so we have, you know, Candida albicans, which is probably the most common one that we see, but then there are bunch of others that are even more resistant. So the first thing is, if somebody has a yeast infection, we usually say start off with the over-the-counter Myonosatol or Monostat. Most people know it as Monostat. And there's Monostat. Historically, we started off with a 7-day regimen. Then we realized if you go with a slightly higher dose, you could do it for 3 days. And now there's Monostat 1 dose. You use 1 dose, it's higher. You put it in and it gets rid of that overgrowth of the more common type of yeast. And so typically we'll tell patients start with Monostat, or we'll prescribe you the prescription version of Monostat, which is known as Myonosatol. If for some reason you're not getting better, then usually that's when we'll culture. We'll actually take a sample from the vagina. If you're not getting better, if you keep having them, and it's not because of like antibiotics and so forth, if you just seem to keep having yeast infections, recurrent yeast infections, then we'll culture, because we want to see what Candida species are we dealing with here, because it might not be that common one that we call Candida albicans. So that's where we start. And we treat, because with the culture we can get specifics about what type of drug to use. So sometimes we have to go to turconazole or ketoconazole, which includes a oral version, diflucan. So there's that. But other things we do is actually lifestyle, right? And so one of the things is, it's not well publicized, but for example, if you're someone who either has a partner who was born with a penis, or you're someone who you're using devices, or you're sharing devices with a different partner, we talk about device hygiene, right? So if you have toys you're using, etc., making sure they're clean between use, etc., you sterilize them well. If you have a partner who still has foreskin, making sure they're cleaning well, because they could actually be reintroducing yeast and other bacteria into the vagina. That's changing the pH as well. So we talk about getting your partner, and sometimes you actually have to just treat the partner. We prescribe the partner diflucan, especially if they're uncircumcised, because that could be the source. And so yes, if you're someone with recurrent yeast infections, any recurrent infection really, and yeast is, like I said, it's not really an infection, it's an overgrowth, a pH shift. Same for bacterial vaginosis. But if we see it keep happening, we definitely hone in on the partner. And if there's not a partner, or if it's a same-sex partner, we also hone in on toys and devices and so forth.
Now, can bacteria, the vaginitis bacteria, can that actually be mistaken for a yeast infection?
Many people mistake it. We don't, because we have special tests to distinguish them. But yes, it's not uncommon for patients to call in and say, I have a yeast infection, but in fact what they have is bacterial vaginosis, BV. So a yeast infection is known as vaginitis, which is inflammation, whereas the overgrowth of the bacteria is known as vaginosis. And so, yes, it's not uncommon for patients to confuse the two. It's also, while not super frequent, it's not infrequent that someone can have both at the same time. And so again, it's really looking, so, you know, if your doctor is telling you need to come in because maybe you called in last month and they prescribe you diflucan, and now you're calling again, or you're calling 2 weeks later and you want another dose, it's not because they're being intrusive. They want to make sure. They want a culture to make sure they're not missing.
And can that also be a sign of diabetes? I see Mama Stu asking that question.
So Mama Stu is right. If someone's blood sugar is really high, yeast grows on sugar. If you're not sure, if you've ever made bread, the way you actually get your bread to rise is you put yeast, you add a little sugar, and you either leave the sugar and yeast to rise first, or your dough and you cover it, and the yeast is going to grow, and as it grows, it makes gas, and hence the bread rises, right? That's how you get dough to rise. It's yeast. So we have similar things going on in our body. Like I said, we have billions of microbes on our body. That includes yeast. So we have Candida, which if it's in the mouth, we call it thrush. That's how you see in babies. You see it in people who are immunocompromised. But the others are those whose blood sugar is so high that it's just feeding. There's lots of sugar to feed on. And so, yes. So that's what I was going to get at. The other thing is we talk about nutrition. So that's when we talk about cutting back on carbs, especially simple carbs in your diet. We talk about making sure that you have more fiber in your diet. So there's more stuff for things like yeast and so on to work on in your gut to help you break down. I don't recommend putting yogurt in the vagina. I know a lot of people out there have been reading on blogs that you do that. There are other people doing boric acid suppositories and doing the yoni steams and stuff. I would tell you boric acid has its risks, but really the first step is, again, look at what you're eating. Look at your partner. There's a lot more genital oral contact happening. So it's not just looking at your partner downstairs. You might want to figure out what's going on with their own oral health, dentition. This isn't the life for that, but I am a huge proponent of dental health because oral health is tied so much. Our mouth health, the teeth, the gums.
Yes.
It's tied to your heart. It's tied to your heart health, your stroke risk. But also it's tied to down there, the health down there. And so, if you're dating, you want to know if they're seeing their dentist regularly. You want to know.
Mama still be on me about my dentist because I'm terrified, but I go.
Mm-hmm. Yes, dental health is a big deal.
It's a big deal. Now, let me really quickly, before I get to the last couple questions, you guys, and I'll just say my own little story with this. I don't think that there's a woman, Mama Stu says, yes, Dr. Duke. I don't think that there is
I'm not seeing the comments anymore, so you have to tell me. Yeah, the last thing I see is Clint Individual, who had which is probably like half an hour to 45 minutes ago. So I'll have you read
coming up. Is anybody frozen? Is everybody good? You guys can see. Give me thumbs up if we're good, because Dr. Duke can't see your comments, but of course they're coming like crazy.
Or reactions anymore.
Oh wow! And pregnancy after pregnancy, my teeth were like, "Girl, what is going on?" You guys, give me a thumbs up if something is wrong with the live. Let me know. Some people are saying they're good. They
okay,
can
it's
see
probably
you.
just my end. Yeah.
Well, then I will let you know. Okay, we're getting thumbs up. But since we're here, since we did the yeast infection, another thing that we've never done is bladder infections. Yeah. And I think that that's something to just briefly touch on. Thank you guys for the thumbs up. I see them. Bladder infections. Now, I'm gonna just go ahead and be honest, y'all. I was in college. I had a boyfriend, Luis Alberto Laporte Jr.
That name already.
Yeah, honey, because he was Puerto Rican and black, baby. When he spoke to me in Spanish, I was happy. Okay, I was happy. Now, my mother taught me all about sex and protecting myself and doing all of the things that I should have been doing. And Luis is still a friend, not a boyfriend, but still a friend. But I did have unprotected sex, and I did get my first. What the hell? I'm peeing. It burns. I'm peeing every 25 seconds. And then it started to get like a little bit of blood. And then I was so scared to go to the doctor to call my mother because I didn't want to get cussed out from Philly to New York. I was so scared that I went online and I got the cranberry juice and I got the UTI powder, Demonose powder and all of that. But can you talk to us about sex, bladder infections?
Yes.
Knowing how to get treated properly, and if there are any myths in the natural cures, can you debunk them for us?
Yes. So my mom just texted me saying my live is frozen, but good info. So I'm guessing for some people it's frozen, but it sounds like they're hearing us. So that's good. So bladder health
for me.
Yeah, I see you well, and it looks like you're
not frozen for me.
Yeah, so but I know something's frozen somewhere because the feed froze in terms of the comments. But it sounds like she can hear me. So
she can hear you. Okay.
The big thing about bladder health is your bladder health is really important for those of us who are born with a vagina, etc. The thing is, our design is such that we have a very short urethra, meaning the tube that leads from the bladder to the outside world is very short. For us, it's about 3 centimeters long, whereas for those born with a penis, their urethra is up to 15 centimeters long. So very different. So the point is, because it's so short, it's very easy for bacteria to get back up in there. And so it's why, for example, we say from the moment you start potty training your little ones who were born with a vagina, you teach them to wipe from front to back and not the other way around. Because if you're wiping from back to front, it's very easy for bacteria to get introduced, and they can quickly make their way up that short urethra and cause a bladder infection. So first thing I ask everyone is to make sure they're wiping from front to back. From time to time, I come across adults where they don't really do that. They just like dab, you know, and so you got to wipe from front to back always. Same thing for hygiene. When you're showering, you make sure the area is clean and the area between the labia gets cleaned. In terms of intercourse, we actually say definitely just general sexual hygiene is you should pee before and pee after. Right?
That was the key. Peeing after. Well, it wasn't. I didn't know before, but peeing after.
Yes.
And going through all the cleaning routine before and after. But yes,
that's a big
tell
deal.
Us why.
So pee before and after, because again, there's just so much activity happening, and who knows what activity you're engaging in. And like I said, if there's like genital oral contact, you're literally now introducing bacteria that usually live in the mouth down to that area, and that can be a problem. And who knows what someone's mouth is colonized with. It depends on their activity, but it also depends on their own oral health. Are they seeing dentists regularly getting their gums checked, making sure they're flossing, getting rid of plaque and all that stuff, you know? And I'm not going to lie to you guys. We have and we do diagnose people with infections down there that are with bacteria that we know reside in the mouth. I'm just letting you guys know, right? We know this stuff. We've seen it happen, even in pregnant women. And so there's that. So that's the other thing, right? So before and after. If you're someone who knows that you actually have this happen, we actually would give them prescriptions. So we have patients that we prescribe medicine to, and we'll tell them, if you know you're planning sex, you start your antibiotic that day and you take it for 3 days. For others, oh, it was spontaneous or right after, you make sure you pee, but you also take your antibiotic for 3 days to prevent an infection. Because there are those people for whom they're very prone, and after sexual activity, they will have that bladder infection. So that's how we address that. For others, it's because they did antibiotics, whether it be for a toothache, maybe you had a stomach infection, a lung infection, a vaginal infection. Because you took antibiotics, we then make sure you are on something that'll prevent either bladder infection or yeast infection. Some people get yeast infections after antibiotics. So really, it's what we've always talked about, Kelly. Know your body. Learn your body. Right? If you're that person who always gets the infection after antibiotics, you want to tell your doctor, this is what always happens to me. So they can preempt and prescribe what you're going to take following your antibiotic. If you're someone and you're not sure if your UTIs are related to intercourse, keep a journal, right? And really, you know, it doesn't have to be anything fancy, just a little note on a calendar, maybe a star or something that lets you know that was the day you had sex. And then you have another symbol for when you start having symptoms. And it lets you know what? It's like clockwork, 24 hours after. Yeah.
I started to do that. I started to keep that journal because after it happened to me, you remember the first one was like I was in college, and after it happened to me the second time, I said, oh no, whatever this is, I don't want it. And that's when I called my mom and let her in on it. And she's like, this is what it is. It's a UTI. This is why, blah, blah, blah. And then I got educated and learned how to pee after sex. And it changed everything. But still, drinking that water, that cranberry juice, and just knowing that this is something that happens.
It happens.
And we have to talk about it. Yes.
Kudos to mamas too for responding in the way she did. Because this is the way moms should respond, parents should respond. And you're going to get those calls from your college-age kids. You will. And it's not to judge, oh my God, I didn't send you to school to do it. Answer them, provide them with the information, or provide them with the resources, which is there are lots of telemedicine services available as well. If that's a conversation you don't want to have, then make sure they have the resources so they're not sitting around in pain or in shame.
Yeah, in pain or in shame, and allow them to know that what they're going through, you've also gone through. Because just knowing, just her saying, I understand, mommy's had it too. I tried to quit college, y'all, and then I'm going to get to the last question. I was crying hard one day, and I told off my dean, Israel Hicks, in heaven, and I quit. I told him, I'm done being an actor. You can't tell me nothing. My parents pay for this, and I don't need these problems. And I was crying and going crazy. And he called Mama Stu on me, y'all. My dean called Mama Stu and said, you know, she trying to quit. My mom said, she must be hormonal. I'm on my way. And she got in her car in Philly and drove to New York.
I love
But
it.
you know what she did? She held my hand and she said, your feelings are valid. It's okay. I think you have PMS, because my mother knew, you know, how I get emotional. But
Yes.
it's okay. You didn't quit school. You just quit for a day. That's it. But this will pass. But there's, you know, and I know that I can't loan Mama Sue out to everybody, but I just wanted to share that story to know that we are out here. We understand what's going on. So we all have something. So let's get to our last question or two here. That Mama Stu said about diabetes. This will be our last question for the day.
Yes, as for diabetes, it means get your blood sugar under control. If you're diabetic and you keep having yeast infections, it's not just the doctor treating the yeast. It means you got to do better with your
You got to do better with your blood sugar. Okay, I love that. Thank you for that. We have Joy Fit Pro. How many embryos do you put in a woman over 20, 30, 40, etc.? So I think the question is about how many embryos do you implant? Yeah.
Well, it depends on if the embryos were tested. Rule of thumb at my clinic, and my patients know this, if you're under 35, I especially encourage one, because the chance of pregnancy is very high. The truth is, whether you put 1 or 2 embryos isn't going to change whether you have a positive pregnancy test. What it changes is how many babies are in there when we do the ultrasound. And of course, the more babies, the more risks there are to not just the person carrying the pregnancy, but to the babies themselves, because there's higher likelihood that you need to deliver early to usually help save the person who's carrying the baby's lives, but that means they're born early. So then the risks of prematurity come in. So I strongly recommend 1 embryo in people under 35. Now, notice I said recommendation. And that's the same as the recommendation coming out of the American Society of Reproductive Medicine. We have a lot of patients who want 2. At my clinic, we have a conversation. If they still want to, I'll document that. I document that we went over the risks of multiples, which is if we put in 2 embryos, again, your chance of pregnancy isn't different if we put 1 or 2. But what's different is the chance of twins, which is 79%. If we put in 2, the chance that there'll be 2 babies there when we do ultrasound is 79%. The chance of triplets is also significant, and the chance of quadruplets is significant. So that's why we counsel strongly on 1. But if people want 2, I never put more than 2 in someone under 35, period. Over 35, if they've done genetic testing, which is pre-implantation genetic testing, PGT, so we know the embryo chromosomal status, again, I recommend 1 at a time. I'm a huge proponent of 1 at a time is what you can tell. However, if the embryos were not tested, then we now have to start factoring in the impact of age on embryo and embryo quality, meaning if the eggs were older than 35. And so we have guidelines which say, you know, up until 37, 1 or 2. At 37 to 40, 2 embryos are recommended. 3 at 40. By 44, 45, recommendation is somewhere between 3 and 5 untested embryos. And that's because although it sounds like a lot of embryos, the way they perform just isn't.
That's if the eggs were 40 to 45 years old.
Correct. Like the age of the
for me, my eggs are 30, 37
so
years
we're still
old.
going to base it on the age of the eggs when they were frozen.
Got it.
Similarly, let's say you're using donor egg. Most donors are between age 21 and 30. So even though you're 55, I'm going to recommend 1 embryo at the time. Now, some of my older patients, they really want me to put in 2 because they want to be done. They've waited a long time for this, and they don't want to be doing this 2-3 years from now again to grow the family. With that, again, it's a conversation. It's an assessment of that person's health, because every risk of a multiple pregnancy is even further now compounded by her age, meaning risk. The more placentas, meaning the more babies in the womb, the higher the chance of diabetes in pregnancy. If somebody is in their 40s, that also increases their risk of diabetes. Higher risk of heart problems and heart attack, right? So my goal And some people get frustrated at this, but the truth is, as your doctor, especially Cindy Duke as your doctor, my goal isn't simply to say, I got you pregnant so I have another notch in my belt. My goal is that you have a baby and that you live to watch your children grow up. Healthy mom, healthy baby.
And right there is where you drop the mic. Right there is where I believe we say thank you, Dr. Cindy Duke. Healthy baby, healthy mom, that you live long enough to see your baby grow. I thank you immensely for your time, for everything that you do in this community for us in the fertility world. I want you to tell us really quickly where everybody can find you and hear you. Continue to show support. Right before we let Dr. Duke go, I want you to, I really want you to do me this favor. Share this live. I'm going to save it. Share it with people that you know. Share Dr.
Agreed.
Cindy M. Duke with people that you know. She has a fantastic website, the medical director of the Nevada Fertility Institute. She is all things, and she is out here talking all the time. So let them know where they can follow you, please, Dr. Duke.
Yes. Well, you can follow me here on Instagram and on all social media at Dr. Cindy M. Duke. So my handle here on Instagram is identical to my handle on Twitter, on Facebook, on LinkedIn, on Pinterest, on YouTube. I'm everywhere.
Yes.
In addition to that, you can go to drcindyduke.com. That's my primary website. And from there, you can find the page for My Dynamic Uterus, which is the club on Clubhouse, where every Wednesday we talk about PCOS, 7 a.m. Pacific time. Every Saturday we talk about periods, 7 a.m. Pacific time. I know, guys, it's early, but I'm a surgeon. I rise early, I work early. So I like to start those days early and get it out of the way. We also, on the first Sunday of every month in My Dynamic Uterus on Clubhouse, we do LGBTQIA family building. So it's a team of fertility doctors answering questions dedicated to the LGBTQIA
Love it.
community, whether it's talking about fertility preservation, hormonal management, pregnancy. What are my options? Can I even do this? Is this possible? I've been on hormones for this many years. Can I come off hormones and start a family? We're there. We talk about all of this. In addition, on the third Sunday of every month, we just do a general fertility room there. So again, if you go to the website, you'll see all that information, all the up-to-date information. In addition, on the My Dynamic Uterus website, we have an interactive map where you can find like PCOS specialists and stuff, which we started because we see so many people coming into the rooms and they're asking, how do I find someone that helps me get the same information where I'm located? So I'm determined between now and December to really populate that map we're focused first on the US and we'll do some in Canada. But really my hope is within a year from now, we'll have a global PCOS interactive map where you can go hover over the map wherever you are in the world and you locate someone closer to you who has been vetted and is a PCOS expert. That is my hope for you. There's no cost for this. This is really part of my advocacy work and ensuring that people have the information, because I'm only one person. I may not be on this planet. Well, I know I'm not going to be on this planet forever. Who knows when our time will be? I want that the needle has moved forward if I'm no longer here, that the way we look at PCOS, the way we look at multidisciplinary healthcare when it pertains to women, when it pertains to people of color, the world over, that you have access and you feel empowered. And that's also why I work so closely with Calais. It's why I'm excited about the Warrior Wednesday website. So definitely go there as well. Two pieces of exciting news, Calais. I was part of a documentary on PBS Nova. It's called Fighting for Fertility. And you can now view it. Yes, you can view it on the PBS Nova website. You can also find it on YouTube, Fighting for Fertility.
And it's
Guys,
excellent.
check it out.
It's
excellent.
I've seen it and it's excellent. Yes. Okay.
And I'm really proud of it. It really discusses so many amazing things. I'm one of the fertility experts in the documentary, and it was phenomenal. It was, written, directed, produced by Larkin McPhee, who is an Emmy Award-winning producer, in conjunction with or collaboration with PBS. So I don't have IMDb credits, but I am part of it. And so
Oh, they're coming,
definitely
Dr.
check it
Duke. If
out,
I have
right?
anything to do
Check
with it,
it
they're
out.
coming. Yes.
I'm just really excited about it. And I think it brings a lot of information to the front, which people need to hear. And the second is our COVID infertility book. I know I keep sitting on it because, you know, I'm a perfectionist, but it's going to come out next Tuesday. Finally, it's dropping. Calais, you're going to have copies that you can give away too. It's coming. We're going to do it.
A great episode to promote.
We're going to do what? It's going to be great. And it has so many resources, including like what are the codes that you need when you're looking for insurance. You know, there are people who are shopping around for insurance and they think they finally found insurance that covers infertility, only to land at a fertility clinic and we say, no, this just covers testing. It doesn't cover treatment. So I'm actually going to give you those international, what we call CPT codes. So anywhere you are in the world, because there are people in other countries who can also buy insurance that they can travel even to the US and get service with, but they need that information. Yes. And so we're going to give it.
Well, Dr. Cindy M. Duke, congratulations on all of the wonderful things that you are doing. And I know you said earlier, it is your hope to have this network go global. I am saying to you, it will manifest. And if there's anything I can do to be of service to you, you call on me. I know I can speak for every warrior that's in this comment section. We love and support you, and please call on us to do whatever and all things that we can to help your missions go forward. You have been speaking of a dynamic uterus, you have been a dynamic woman in our life, a force that gives us the knowledge and the compassion that we need to be brave enough to take the next steps forward into parenthood or to just living a healthier life.
It's healthier and empowered.
Healthy and empowered. Call on us. We love you. We celebrate you. You guys, I want you to follow Dr. Cindy M. Duke on every single platform. Share this live. I'm going to save it. To your mom, Dr. Duke, we say thank you, mommy. Even though she might have been frozen for you, she is looking fabulous. Makeup is done. Haircut is pressed on our live. You guys, Dr. Duke, of course, when she has the time, will come back on Warrior Wednesdays. Every time I ask her to come, she makes the time to be here to speak specifically to you. I thank you for 2 hours of amazing information. We adore you. We love you. I will be texting you soon, sis, after I get all this saved. I thank you. I thank you. And we will see you the next time you can come on by.
Absolutely. And thank you for having me. And everyone, thank you for your questions. They're always so enlightened and so impassioned. I love it. Thank you.
So great. You look beautiful. Congratulations on everything.
Yeah, I decided it's the first time I've had hair this short in over 10 years. I think it was needed. And going on vacation after a year and a half of pandemic and truly burning the candle on both ends, trying to make sure everyone knows the truth about COVID. It took a toll. And so I made some commitments to myself, including cooking more of my own food and sharing it because I love to share. And if it wasn't for pandemic, I grew up with a mom who loves having dinner parties and, you know, she had a restaurant. So I grew up loving to interact with people over food. And so as I take charge of my own health, I want to do the same for everyone else. And food is amazing. We have to do it in moderation in terms of knowing your serving size and stuff. But I think the more you know about the nutritional benefit of food, the more you're excited to eat it when you learn how it's working.
What it's doing for your body.
Yeah.
Well, listen, I'm vaccinated and you're vaccinated. So one of my next trips is going to be to the Nevada Fertility Institute.
Yes.
Just to come over there and to say hi to you. And we'll figure out a way to record a live or cook some food together and continue these great conversations. But you are amazing and awesome. We thank you. We congratulate you on the documentary, on your book, of all the things that you are doing. And like I said, and I echo this for Regina Townsend, Michelle Polston, and all of my girls that are out there, whatever you need from us, you call on us. You can count on us. We are here for you. So thank you so much, Dr. Cindy M. Duke. You guys follow her, and we will see you next week. And there's going to be more to talk about. And when Dr. Duke can come back, I'm sure she will. So thank you guys for being here. Mwah. Love to you.
Bye, everybody. Take care.
Bye, guys.